Welcome to our conversations with authors of articles in the Innovations in Hepatitis Elimination series for clinical liver disease. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia, and the associate editor of clinical liver disease for this series. This is our second webinar conversation in our series, and very excited to have Dr. David Goldberg with us today. David is an associate professor in the Division of Digestive Health and Liver Disease at the University of Miami Miller School of Medicine. He has over 100 scientific publications on a variety of different topics, including looking into health disparities for persons with advanced liver disease and hepatocellular carcinoma. And perhaps in part directed him to the body of research that we'll be talking about today, which is looking at screening interventions for hepatitis C that really bring together recommendations that were made at different points in time. Of course, the virus, hepatitis C virus, was discovered around 1989. Screening tests became available in 1992. Recommendations from CDC issued in 1998 began to identify populations at risk for hepatitis C and recommended testing for them, including children born to HCV-infected mothers. And then fast forward to 2012, where CDC recommended a one-time hepatitis C test for all persons born between 1945 and 1965, the so-called baby boomer population, and then that was put in place. David and his colleagues then came up with a novel approach of identifying children of baby boomer aged mothers who have been found to be HCV infected, and then to develop a screening outreach program to reach them and to offer testing and treatment for them. So I'll turn it over to David now to introduce himself further and to begin to describe the study. And then following this, I'll begin to ask some questions, but I encourage the audience to do that as well through the Q&A function at the bottom of your screen. Thank you, David.
Thank you very much, John, for the introduction. So I am currently a faculty at the University of Miami, but this work was conducted when I was previously at the University of Pennsylvania. And the way this started was I was the medical director of living donor liver transplantation. And so I would see all of the potential living liver donors. And there was a young man in his early 20s who had no risk factors at all. And as part of the first step of screening to be a donor, we checked viral serologies. And his hepatitis C antibody was positive. Subsequently got a hepatitis C RNA that was positive as well. And this sort of took him as a shock and us as well. I had not met him until this point. But he had no idea. He had never had sex, never used IV drugs, never blood transfusions, like nothing in his life. He was a college student. And then when we got his hepatitis C genotype, it was genotype 2B. Now, I knew that his mother had hepatitis C as part of the process, but he could not be aware of his mother's history. When I saw him for the visit, we started discussing risk factors, and I said, well, is there anyone in the family? He said, well, actually, my mother has hepatitis C, or had it. She had been treated. I never knew she had it before this. She never told me. We never knew that I could have gotten it. His mother previously was genotype 2B as well. Now, she had already been treated. We didn't have samples of hers to sort of do a phylogenetic analysis, but it seemed fairly conclusive or obvious that he had probably had perinatal transmission of hepatitis C and never knew it. It then got me thinking, going into the literature about sort of what is the risk of perinatal transmission. And like John said, there are recommendations to screen children born to HCV infected women, but those guidelines didn't exist 20, 30 years ago. especially before we even knew about hepatitis C. And I started thinking in my own practice of when I had women that were baby boomers who likely were infected during their childbearing years. I never asked them, have your children been screened? And I asked my colleagues, and most of them said the same thing. So we sort of did a back of the envelope calculation and said, wow, if 1 in 30 baby boomers has hepatitis C, about half are women, most were infected during their childbearing years. The average woman, 50% of women have children. Sort of do the math, and there could have been, 50 to 100,000 people that have hepatitis C and have no risk because of the reported risk of 5% perinatal transmission. So we wanted to really do a study to estimate how many potential children of baby boomer women might have hepatitis C. So I did approach Gilead, and this was funded by Gilead through an investigator-initiated grant. And initially the goal was, I said, I want to test thousands of women, approach them, test their children to estimate the prevalence. They said, I had, $1 million grant that I proposed to them. Their response back was, let's get some prelim data on if people will be willing to do this. And let's start maybe, 1/10 of that and see what we can do. We started doing some prelim work and discussing this with mothers, and it was apparent that most of them didn't know that their children could have it, but that getting mothers to consent to discuss it with their children and get tested was not so simple. And the study sort of pivoted from get the prevalence to actually find out what the barriers are to even operationalizing this, keeping in mind that this was started before universal screening recommendations. So the way we designed our study was that we would approach mothers with hepatitis C or baby boomer women with hepatitis C engaged in care in our liver clinic based on our electronic medical record and those who've been treated, approach them and say what we're doing this study. We want to see if your children could be at risk, explain to them why we're doing this, and then say we could offer free testing of their children. So Gilead would pay for the testing if patients didn't have insurance, and as well as they would pay for study drug if someone was found to have hepatitis C and didn't have insurance or the copay was prohibitive. So we started this out. We started contacting women, calling, and it was largely my research coordinator who was the first author of the paper, Maureen McCauley, and we were really not having much success. Most of the women said, I'm not interested. There's no way my kids could have gotten it. I had hepatitis C. I developed hepatitis C 10 years ago. Obviously, that was when they were diagnosed. I'm not interested. And there was a disengagement. So I actually reached out to a colleague, Stacy Truskin, who does a lot of work in sort of hepatitis C testing, and told her my dilemma. And she was very helpful. And the three things that she said to do were to provide some information to the parents and to their children, very brief of like, what is hepatitis C? What are the risks? To offer incentives both to parents and to children, and also to engage their providers. So it was my research coordinators that were just cold calling people, and that wasn't really working so well. So we engaged, we had, I think at the time, 5 advanced practice practitioners in our hepatology practice who really saw the bulk of the people with hepatitis C. And we engaged them, they were collaborators on the research, to approach their patients to see if they would be willing to consent. That made things much better. We were able to get many more mothers involved, but despite all of that, we approached 260 women, only 40% consented. Those who didn't consent said, I don't want to give you my children's information, I don't want them to know, or there's no way they have it. What we found was that, of the 100 mothers that consented, they had limited understanding of hepatitis C. So as an example, almost half of them had a history of IV drug use, but of those, 40% said that IV drug use could not have been their risk for getting hepatitis C. The majority thought that they were infected when they were diagnosed and not 20, 30, 40 years ago. There were some differences by race. We found that the white women that we interviewed, about 60% knew that they could pass it to their children as compared to 30% of blacks, but you could argue they both were quite low. And the big thing that we focused on with the parents was we wanted to say, once they consented, how would you like us to contact your children? Would you like to have us cold call them yourselves? Would you like to do it yourself and ask them to call us, or would you contact them first and then we contact them? We thought that either of the approaches could work because 85% of the women said that their children knew about their diagnosis. Now, we obviously couldn't confirm that. We took their word for it. Now, of the parents, of the mothers, almost 40 of them, so 40% said, we'll contact our children and ask you to contact them. That strategy didn't work because we were 0 for 40 there. Of those that we contacted, the majority consented. Well, of the 60 that consented, only 30 got tested. And this is, again, only 30 got tested of those people who were given education, $20 incentive, free lab tests, and the opportunity to get free drug when they were told that they could have a 5% chance of having hepatitis C. In terms of why they didn't get it, some children said, well, I would know if I had hepatitis C. Some thought they'd been tested. They said, oh, my doctor checks, my regular test. Well, back then, this was not universal testing, so it would not have been part. Some of them, and of those that consented, a lot said they were too busy. So about 12 out of 30 who didn't get it said they were too busy to go to the lab. And again, how long does this take? Or they lost the paperwork. And even though we explained that LabCorp, when we put the order in, it's in their system, they still said, well, I lost the paperwork, so I couldn't go. So I think that, from our initial goal of estimating the prevalence of this was obviously we couldn't really get it. Of the 30 we got tested, 28 were negative. 1 was antibody positive and RNA negative. And 1 was sort of entered in because, like my patient, there was another person in their 20s, no risk factors, who had hepatitis C, likely through his mother, who was able to participate. So the real take-homes were not the prevalence, but that even in a population that is arguably high risk, who's given education, incentives, free testing, the uptake of the hepatitis C testing was quite low. And the knowledge about that, and again, I think this is something for all hepatologists or anyone who has patients with hepatitis C, is mothers don't realize and they don't necessarily appreciate that they were likely infected 20, 30, 40 years ago. And for those of childbearing age, they may have passed it unknowingly to their children because we didn't know about hepatitis C. And I think that was something interesting, is how many of the mothers sort of didn't temporarily sort of relate everything together. John, you're muted. Yeah.
No, thank you for that overview. It really, even though there was a lot of non-response and a lack of participation, it doesn't mean the study wasn't revealing.
Yes.
Sometimes we're swimming against the current of publication bias, where it looks like, because of those factors, sometimes research doesn't get published. But in this case, I think it's very revealing of some of the barriers and what you have to work through to get participation into a public health intervention, such as screening and linkage to care, beginning with the mothers who had different responses to their providers. And so I had some questions about whether you thought, did you look at how long they had been in the clinic, or how long they had a relationship with the provider asking for their participation? I think you did notice that, or did note that in-person solicitation was more effective than by telephone for the mother.
Yeah, so that's if I had to do this again, so we know the in-person consent rates were much higher, and the ability of them to give us their children's contact information was higher in person. The one thing that we didn't note was, because sometimes, if a patient was coming to clinic, my research coordinator would go to see the person. We didn't differentiate, was the person approaching them the research coordinator or the PA? And I think that's something that I wish we had done. I think anecdotally, when it was the provider that knew the patient, they were much more likely to consent and participate. But I don't have the exact numbers. I think that's one thing that I wish we had collected.
Mm-hmm. It also looks like just perhaps part of routine clinical care, routes of transmission and risk of transmission to others isn't really discussed with the patient. They're not getting that education, as part of their clinical care. So, do you think that's?
Yeah, I think, it's interesting because I sort of think about when I see patients, and I think a lot of us, we focus on the transmissions now. If we have a patient who has hepatitis C or any viral hepatitis, hepatitis C, we talk about the risk factors now, sharing needles, even the risk of sexual transmission. I think a lot of us don't think about when were they infected and when they could have passed it on. It's almost like, we lack a contact tracing sort of framework in the setting of treating our patients with hepatitis C.
Mm-hmm.
I think it's a public health thing that I think the general person, the general GI liver doctor, ID doctor, maybe the ID is probably possibly better, doesn't think about that sort of contact tracing thing and how many people could they have encountered in their lifetime who could have been exposed. We think about that a lot more, I think, just with hepatitis B, because we think of it as a more transmissible virus. But I think that's something that maybe gets lost is, if this person was infected 40 years ago, who could they have passed it on to?
Mm-hmm.
Which gets at the question of, why arguably universal testing is probably better, because, you can only do risk-based testing if you actually know someone's risks. So my patient who came to be a donor, he thought he had no risks because he didn't know that his mother had hepatitis C. So
Mm-hmm.
if that person had never been going for donation, unless he had a primary care doctor who was doing universal screening, he could have been 20 years down the road before he was diagnosed.
Right. So having testing routinely offered as part of a preventive care visit or general medicine visit.
I think that as it gets to that, we talk about sort of feasibility. So, our GI practice here now checks everyone when they come to clinic. It was a pilot. I'm not sure the results for hepatitis C with a point of care antibody test. And, that's something to think about, sort of what we were thinking of doing, some sort of point of care testing for the children. But, you wonder if that should be something that is in the primary care clinic. I saw my primary care doctor 9 months ago. I work at a hospital and I still haven't gotten the cholesterol test she wanted me to get.
Right. Well, that's why electronic prompts are, sometimes in some medical centers, the Hep C test is just automatically added to the battery of tests for baby boomers because of the automation within the.
But I guess you have to get them to the lab. So if you could do a point of care test in the office,
That would be increase your certainty. Clearly. I didn't know if you looked at the stage of liver disease for the women in the clinic as far as their receptivity, thinking that perhaps they had a better sense of the seriousness of hepatitis C because of their own symptomatology.
we didn't. Now, we didn't specifically. Now, sort of again, anecdotally, didn't capture this. The patients that we had post-transplant who we contacted, they gave us all their children's contact information. But what was different, though, is those patients also were much more likely for their children to already know. So a lot of the resistance we got of women who didn't consent was, I don't want my children to know I have hepatitis C, because again, because there's still stigmas, especially in certain communities, if you tell your child you had hepatitis C, well, then people are worried, well, they'll automatically say I did drugs 30, 40 years ago.
Yeah.
And I think it seems, again, we didn't capture this. And again, that's something else that would have been nice to do, is that the more advanced the liver disease, the more likely it was like an open, it wasn't a secret. But many of the moms, and I think that was part of the lack of consent, was, I don't want to discuss this with my children.
Yeah, I mean, as I was reading the article, a lot of family dynamics, started coming to mind. It's just, really revealing in terms of the different options that women would take for notifying their children. Right? Speaks a lot about, the different types of relationships people have with their adult children.
Right. And again, I think that's one of the problems with risk-based testing, is that you have to know that you're at risk.
Now, it's true. You would think once you are notified of risk that it would only heighten your your concern and willingness to be tested. It was you know, I did find it somewhat reassuring that once contacted, there was a fairly high receptivity to say yes, you know, we'll go and get tested, even though they did not, many of them did not follow through. It might take some additional interventions to get them to the clinic, but at least they seem to welcome the information once they received it.
Yeah, I think one of the barriers there we found is that we had a couple of people who kept on saying they were going to do it, but they worked jobs that they were not able to take off during the day to go to the lab. Now, again, they could do Saturday, but when you're a younger person and you think you're healthy, I think there's that sort of the psychology of like, I'm fine, I don't need to carve time out of my day for this. I think that was one challenge.
Mm-hmm. Mm-hmm. Yeah, when we first put out the baby boomer recommendation, and I would go and give different presentations, I would more often than not get this question, what about children of baby boomers? So it was that's why I found the study in particular interesting, because there really had not been a study that I had been able to find really directly looking at this at this question. So I think it's really a very novel study that providing some data that fills a key gap in our evidence base regarding testing and how to apply them. And then the proportion that you found, about 3% being positive, is right about the typical transmission rate for HCV infected women to their children. Slightly higher based on if they're HIV positive, it could be as high as 10 to 12%, or if they have particularly high viral loads with hepatitis C, it also increases transmission risk. But typically, as was noted in David's introduction, it's about 3 to 5% typically transmission rate. Now, fortunately, beginning this past spring, we have a recommendation from CDC and the U.S. Preventive Services Task Force to begin to screen all adults for hepatitis C virus infection, and with an explicit mention that pregnant women should be screened, and that's gathering support for that to be integrated as part of screening practices for pregnant women, along with HIV and hepatitis B virus and other screening that's recommended for pregnant women. Usually it takes about a year for systems to put in place a U.S. Preventive Services Task Force recommendation. So hopefully that implementation is underway so that pregnant women are detected, and then those newborns that are being exposed can be identified and then tracked to see if they develop chronic infection. Typically, you're looking at about a 70% risk of chronic infection for adults. It looks like it could be a little bit lower for children infected at the time of birth. There's a longer period of clearance of HCV virus, and so you get a slightly lower proportion that have remaining with chronic HCV infection. Also, there are now new recommendations for treatment include older children. Haven't quite got down to younger children yet, but hopefully the combination of routine testing of pregnant women, very high level of detection of children being exposed to HCV at birth, and then tracking them to see if they're remaining chronically infected so that they can be cured. This sort of phenomenon of children aging into adulthood with chronic infection will become much more of a rare event in our country in the future. Then also, the other aspect of treatment is, can you treat an HCV infected woman during pregnancy if she hasn't already been identified earlier and been treated? Can you treat them to really eliminate the risk of transmission? And those studies are underway. And David, I don't know if you have any information about that just in your own, you know?
No, so when I try to pitch this study idea, it seems like those questions of data of safety and pregnancy were still being worked out.
Yeah.
One of the things though I had to say that sort of came out of this is you mentioned, if we talk about the baby boomer children, and if we do think there's a lot of them, is how to reach them, because obviously the women who are pregnant are going to be engaged in care. I would, many or most women will least likely see their OBGYNs on some regular basis for pap smears or whatnot. But, might that be a point of entry to tests? But for men, I'm a physician. I went 8 years without seeing the primary care doctor until my wife made me. And I think a lot of the patients we had, especially the men in their sort of 20s to 30s and even 40s, didn't ever see a doctor. So the question, I think, is sort of how to reach them. We had talked about, at least for the youngest, is, college campuses as a testing platform for at least kids, in the 18 to 22 range. Obviously not everyone goes to college, but I think that will be the sort of question of operationalizing is how are you going to get it to them? Because if they're not engaged in care, it won't matter what the recommendation is. It's sort of, we have to get a point of entry to the provider.
Mm-hmm. No, that's exactly right. I mean, when we were considering baby boomers, at least people in that age group, if you look at the statistics, a very high proportion see a clinician at least once per year.
Right.
So that does provide an opportunity for screening. That's much, to your point, it's much lower proportion for younger adults. More so for women, as you point out, than for men. But where is that intersection of that population you're trying to test with the health system so that they can be routinely tested is going to be the new area of implementation research that really needs to take place. And obviously you combine it with HIV testing, and there's other opportunities for integration. But that's what we're looking forward to really fully implement these new recommendations for routine testing for all adults. And I think some of the challenges that you reveal in your study will be very helpful to identify the barriers that really we need to work through to scale up testing and treatment. I do not see any other questions. I see it's 11:30. So I think we will, do you have any closing remarks, Dave? I'm going to thank you again for your study and really thank you for sharing your time with us today.
No, I think like you said, this was, when we weren't getting people to agree, we were starting to see as a negative study, but I think identifying the barriers was an important finding of the study. So,
Yeah. Please read it. If you have any other questions for Dave after the fact, please send them along to us here at the Coalition for Global Hepatitis Elimination, and we'll forward them on to Dave, or I think Dave's email is in the article and you can communicate with him directly. Thank you all, and then there will be a recorded version of this webinar up on the Coalition website. Thank you all again for attending. Thank you, Dave, again for your time.
Thank you so much. Appreciate it.
All right. Bye-bye.
Bye.